Good morning, everyone, and thank you for joining us for this important session on dementia risk reduction in the age of COVID-19. Those who follow our work will have noticed that this is the second risk reduction session that we do this year. And this is because of something very positive, which is that there has been a new publication over the summer headed by Gill Livingstone, who will tell us more about that soon, which has added to our existing knowledge around risk reduction. Last year, in 2019, we did a global survey of 70,000 people, and that revealed that almost 80% of the general public are concerned about developing dementia at some point in their lives. And 1 in 4 people believe that there is nothing at all that we can do to prevent dementia. So this raises an important question about the awareness and the effectiveness of our education instructions around risk reduction and whether we need more campaigns, more messages. This is the framework in which we are focusing on this webinar. And when I speak about we is Alzheimer's Disease International, of which I am the CEO, Paola Barbarino. So welcome you all to this session. In these moments of difficulty and COVID-19 pandemic, I'd like to remind you all that ADI is a charity and that we are currently running an emergency appeal, which has been wonderfully subscribed by so many of you. Thank you again. This has also helped us in turn to help our members all over the world. There is 102 countries in the ADI membership, 1 member per country, usually the largest Alzheimer organization in that country, and also 12 members in our membership development program. So you've really helped with your donations further and advance the cause of global dementia wherever you are. Now, without further ado, we should pass to the substance of this webinar. We are going to have a fantastic roster of speakers with us. And first of all, I should introduce you to Gill Livingstone, who will speak shortly, who is a professor of psychiatry of older people in the Faculty of Brain Science at UCL. Then we'll have Diana Blackwelder, dementia advocate and board member of DAI in the US. Sonia Desuza, who is a carer from the British Virgin Islands. Then we are presuming that probably you will get a little bit tired by that, so we want you all waking up. So we'll have a brain gym session with our wonderful ADI Director for Asia Pacific, DY Suharya. And then we're going to start a new round of speeches, very short. Professor Craig Ritchie, many of you are familiar with, is the Chair of Psychiatry of Aging and Director of the Center for Dementia Prevention at the University of Edinburgh. Nina Renshaw, who is the Policy and Advocacy Director at the NCD Alliance. Dr. Melinda C, who is the Associate Professor of Epidemiology and Director of the GW Institute for Brain Health and Dementia at George Washington University, I should have added. And throughout those presentations, we'll have polls that we will ask you to answer to. At the end, we'll have a question and answer session. Now, I should remind you that if you want to let us know who you are and want to say hello to everybody or tell us that you are from a particular country, you can use the chat function. If you want to put a question for our panelists, and we will have a question and answer session at the end, you can use the Q&A function. For those of you that are wondering whether slides of this presentation are going to be available, yes, they normally are available on our YouTube channel about 24 hours after the webinar. So with this, without further ado, let me introduce you to Professor Gill Livingstone, who is Professor of Psychiatry of Older People, Division of Psychiatry, Faculty of Brain Sciences at UCL, and most importantly, she's the lead author of the Lancet report on dementia risk reduction. I should also mention that Gill has been extraordinarily active in the movement to raise awareness of what has been happening in care homes in Britain and further abroad during COVID-19, for which we all have to thank you, Gill. So Gill, the floor is yours.
Hello, and thank you very much for inviting me to talk and for all the work that the ADI is doing, and good morning, afternoon or evening to people from all different parts of the world who I can see are popping up in the chat. So I haven't got much time, so I'm going to talk quite rapidly, which I do anyway, and try and get through as much as possible. So all of you know, because you're interested in dementia, that there are more dementia as there are more older people in the world, as thankfully more people are surviving till old age. So currently it's expected to nearly triple by 2050 to 132 million. And the increases, particularly in low and middle income countries, and that's for two reasons. First of all, people in these countries are living till a later age, and also because there's a higher burden of risk factors there. However, in some of the high income countries, while there are more people with dementia, there are fewer people per 100,000 of older people. So that's the incidence in some, but not all countries are decreasing. And over the last 20 years, there's been about a 25% reduction in the incidence of dementia. That is the number of people who have it per 100,000 older people in the States, France, UK, Holland. So dementia is potentially decreasing in the rate per 100,000 people, but it's not inevitable. And in some other countries, for example, Brazil, in India, Japan and China, it's thought to be increasing. And so therefore, that suggests that we can do something to prevent dementia, but that we must do it or things will tend to get worse. And there's two different mechanisms that are thought to be important about preventing dementia. One of them is to increase what you call cognitive reserve, and that's the ability of the brain to tolerate damage, neuropathology, without developing dementia. And the other is to reduce the damage. And it's important to understand that the reduction in general has been in high-income countries, in high-income people, and that the potential and the need to do something about dementia and about decreasing the number of dementia is particularly important in underserved and deprived populations, in low socioeconomic groups and minority ethnic groups, and in low and middle income countries. So if I can go on, Laura, to the next slide. Our work in Dementia Commission has been to look, or part of our work, to look at risk factors that are potentially modifiable for dementia, and to look at those which have the best evidence. And you can see that they're laid out here on the slide, the 12 risk factors that we've talked about. And they're at different times in life, leading to what we want to say, which is that it's never too early to try and prevent dementia, and it's never too late. And I'd like to, overall, and I'll show you our life course diagram in a minute, overall it makes 40%, but 3 of these risk factors add up to 20%, and these are less education, peripheral hearing loss, and smoking. And these are potentially, so on the one that's the biggest modifiable risk factor is peripheral hearing loss, followed by education and smoking. And these 3 would decrease in theory if they were all modified, would decrease the number of people with dementia by 20%. So can I move on to the next slide, please? So you can see this is how this diagram of the population attributable fraction of 40% modifiable shows that how it goes through life. And we see life really as a river, and these things happen. And you'll see that some of these risk factors are related to each other. So people are not really like rats. You can give one rat diabetes and see, or lots of them are mice diabetes, and see what that does to dementia. People aren't like that. They tend to have several things that cluster together. And so high blood pressure, obesity, lack of exercise, they often cluster together, and diabetes. So we took this into account, and all of them therefore reduces the population attributable fractions. 40% is the best estimate that we have. We took this estimate from the studies, but most of the studies are from high income backgrounds. So it's probably not 100% true for people in low and middle income countries. The 60% of the risk unknown, probably much of it continues to be modifiable, but we're not yet at the stage where we can be absolutely sure about what they are and how much they contribute to it. So if we can move on, because I haven't got much time, to my 4th slide, I want to say my message to you is be ambitious about prevention. There's been some trials and they tend to be short with small number of people. And that might disappoint because something that's been damaging your brain for years may not be easy to reverse in very short times. But the results from cognitive reserve modification for whole populations or high-risk populations are much more hopeful. And probably the most important thing may be policy changes. Getting people to change their individual behavior can be very useful, but it's more difficult for people to sustain this. But if you live somewhere where it's easier to walk rather than always to be in the car, where it's easier to exercise, where good food is, which will be less likely to make you obese, is within easy reach of you, and you're much more likely to sustain this. You're not going to be able to to change pollution by yourself, but government and population can, and they may be the most powerful. And I wanted to leave you with thought that of what you can do individually without randomized controlled trials. So John Snow was a famous British doctor, and when there was an outbreak of cholera, he put the dots in the map and said, and looked at the people who were dying of cholera, and all of them were around Broad Street in London, apart from one family. And he was a very interventionist guy. He went round to the other people who had cholera and said to them, do you have anything to do with Broad Street? And they said, yeah, we used to live there and we moved over here, but the water in Broad Street tastes so much better that we go round to Broad Street and we bring it round to our house. So John Snow told people that that he thought there were little, this was before anyone could see them, bacteria or viruses or particles in the water, and that was causing the illness, and people thought he was crazy. And he then broke the handle of the Broad Street pump, and since then there's never been an outbreak of cholera in Britain. So I'm going to say you can do something, policy can do something, we can do things together, and we can really make a difference to the number of people who develop dementia. So thank you for your attention.
Thank you very much, Jill. That has been such a short and yet such a powerful presentation. We will start our conversation in a minute because there were just so many points on it. But before we do that, I would like just to point everybody's attention. I can see now that we have people from literally the 5 continents. Thanks everybody that has woken up very early or that is going to bed very late because of this. In 2014, ADI published an infographic, Dementia, Can We Reduce the Risk? All of our members, a lot of people around the world will be very familiar with that infographic that had 5 areas. Look at what we have now, the 12 dementia risk factors. The research of Gill has effectively helped us increase, and the research of many, many other researchers around that research has helped us now to pinpoint a lot more risk factors, some of which, like for example, the hearing loss you just told us about, seem to be exquisitely focused on dementia. So this is our new infographic that we are launching today, and we invite all members of ADI and all policymakers that are listening to us to adopt this new infographic for the foreseeable future. And then we hope that we will be forced to update it much faster with more research coming up, but we'll talk about that in a second. Now, we are going to start a discussion with Gill. So I'm going to ask Gill a few questions that probably are on everybody's mind. First of all, I'd like to say that I was so impressed in this study how interesting was the time focus, how Gill focused, for example, how education is one of the early life risk factors. And also that prompted in my mind how dangerous this is, because there is so much that can be said about social justice. So if people are not educated, that effectively means that there is a higher likelihood that they will develop dementia at a later stage. I mean, this is terrible. You know, why are we even hearing this? You know, this is something that we can definitely bring to policymakers. This is about education at large, not education about dementia. And also the very important and interesting point about hearing loss, I think I read it in your paper, so beautifully written and so clearly written. It's really, really important to use every mean at our disposal to prevent hearing loss from being had, because we can prevent it, and that actually is protective. So Gill, could you tell us a little bit more about the one or two things that you found in this study that really surprised you, or where you thought, gosh, just by doing this very small thing, we could help so many more people?
Yeah, I suppose the first thing that when we started with the 2017 that really surprised me was hearing loss. Because I think we've been very used to people thinking that what's good for your brain is good for your heart, is good for your brain. But we hadn't really been used to thinking about the two things that really surprised me were hearing loss and social contact. And they don't surprise me anymore, because now I think, and that's what really, you do research and then you change your thinking. So now I think that it's really important to have a cognitively stimulating, socially stimulating environment. And people who can't hear, we're not exactly sure how it works, but we do know that they tend to have more brain atrophy. But people who can't hear tend to stop going out because they can't stop seeing people, stop socializing, they become more lonely, they become more depressed, become more socially isolated. And they have the easiest way, I mean, here we are now, we're all sitting in a group of us and we're responding to cognitive stimulation very rapidly. Paola says something, I've seen people are saying, will say things in the chat and questions and answers. So it really makes a huge difference to how cognitively stimulating the environment is. So that surprised me and changed my mind. And since 2017, there's been several studies which have shown that the people who use hearing aids have the same risk of dementia as the population who doesn't have hearing loss. And that's a really hopeful and important thing. It doesn't 100% prove it's the hearing aids that do it, but it makes it pretty likely. And if it wasn't the case, it would suggest it wasn't. And equally, I think then with social contact, and I think it's really hopeful, because I think as doctors, we're used to saying, don't do this, don't do that, don't do the other, but actually saying, talk to your friends, go out, be with them, enjoy yourself. That makes you less likely to develop dementia. And it's a really hopeful and useful thing. And I think we should all be thinking about it, particularly in this time of COVID. Are we socially isolated, and are other people socially isolated?
Which, thank you so much, Gill, also prompt us to a number of discussions we've had in previous webinar around mental health issues also, and how those are detrimental actually. And clearly we are now seeing in many of the higher income countries how the withdrawal of social support services is now causing further and quicker cognitive deterioration in those who already have dementia. So clearly there's a lot of causality there. But moving again back to this study, and I can see that there is a lot of questions, and we'll try and pick them up at the end of the webinar. I do have one question for Gill that is quite important for all of us, which is, in the course of your study and your commission work, and I should repeat, in the commission, there's been a lot of academics, a lot of researchers involved, some of whom are on our medical and scientific panel. So I thank all of them for their contribution. Gill, did you see any study which you think in the next 2 or 3 years could yield some further interesting confirmation about some risk reduction factors that you could not include in the study this time?
I think people are trying very hard to find out a bit more about food. Generally, people feel that eating well, I mean, clearly eating well makes a difference to whether you're obese and whether you're more likely to develop diabetes. But I think that it's generally thought that if you eat a good diet, sort of Mediterranean type diet, that's going to help you make you less likely to develop dementia. But it's really difficult to study it because diet is a long-term part of life, and it's inextricably bound up to resources and social class, as well as everything else. But I think people are working really hard to try and think about what the role of diet and to try and get the evidence very much better. I mean, what we do know is that generally vitamins don't seem to work very well. It looks much more like it's an overall diet rather than taking a bit more vitamin E or vitamin B. But I'm really hopeful that over the next few years, we'll be able to clarify that, and not myself generally, but the whole community very much more.
Thank you so much, Jill. I remind everybody that Professor Mia Kivi-Pelto and Jill herself are going to speak at our conference in December, the virtual one, and there's going to be a lot of intervention on this issue of diet, which we're all waiting for with bated breath. Now, I can see there's a number of questions. I think we have answered some of them around social isolation and hearing loss. I can also tell you that the infographics is now going to be formally available on our website. So the team will send in the question and answer chat box the link to the infographic so that you can all have access to it. Now, let me move on from this part of the discussion, although we will continue. I thank Jill, and we will continue to pick up more Q&As at the end of our webinars, but we are moving quickly to Diana Blackwelder. Diana is a dementia advocate from the US. She was actually a Black Belt Six Sigma process improvement, and she was diagnosed with young onset dementia, Alzheimer's disease, actually in 2017. She successfully lives alone, where she cares for her 2 pet cats, travels internationally when, of course, COVID is not there, and advocates for the betterments of life of those living with multiple cognitive disabilities. She's a member of Dementia Alliance International, which many of you are familiar with. Diana, the floor is yours. Tell us about your experience of risk reduction and dementia where you are.
Thank you, Paola, for that wonderful introduction and excellent information, Jill. I totally agree with so much of what I've heard today so far and how it's impacted my life living with dementia. I was diagnosed about a year before the Alzheimer's disease with mild cognitive impairment. And at that time, my neurologist strongly encouraged me to do many of the items discussed in this risk reduction dialogue, including the diet, weight, social interactions, for example. And many of those I had already been doing for a number of years. I think the only thing I hadn't been successful at was achieving a healthy weight. And I still haven't achieved a healthy weight, and COVID doesn't make it any easier either. However, 1 year later, I went on to be diagnosed with Alzheimer's disease. And this led me to wonder if I was to blame for the continued progression and maybe even the cause of the disease itself, since I didn't have a prior family history of dementia. It also led me to initially hesitate further with sharing my diagnosis with others, fearing I was in some ways to blame for my lot in life. So risk mitigation can and often does become a double-edged sword. For me, I was able to put it all in perspective, given I have a strong professional background in cause-effect analysis from my engineering profession, but I wonder how different it might be for others that do not have as strong of a background in the concepts of risk. We can and should leverage lessons learned from the HIV/AIDS risk mitigation efforts with regards to avoiding victim blaming. My negative outcome experience also led me to question the effectiveness of the guidance given from my neurologist. When others have similar negative outcomes, the effectiveness of any existing efforts to reduce risk will be minimized. For example, people who are visibly healthy and exercise regularly, yet still die of heart attacks, is an often heard public narrative for not following heart disease risk reduction activities. And heart disease risk reduction activities are very similar to dementia risk reduction activities. Another shared similarity regards that the risk reduction work must be done consistently for years or even decades without any immediate reward or sense of accomplishment towards the end goal. Heart disease risk reduction has so much in common with dementia risk reduction, but doesn't carry the same stigmas as dementia does. Therefore, any difficulties encountered reducing the risk of heart disease will be similar but more difficult for dementia, I think. For example, heart disease risk reduction techniques often should continue beyond diagnosis to reduce the impact and progression of the heart disease. So it goes for dementia risk reduction techniques, as they too may reduce the progression of the disabilities caused by the dementia. However, because of the stigma that those with dementia are no longer here or are terminal and nothing can be done, and are often spoken of using the past tense by their acquaintances and even their loved ones while they are still alive, it will be much more difficult to implement and sustain these same efforts for those living with dementia. As a person living with dementia that has had success with significantly reducing and in some cases arresting some of the disabilities caused by my Alzheimer's disease through the help of activities including daily speech cognitive therapy, physical therapy, exercise, and lifestyle modifications, I encourage you all to include risk mitigation supports and services post-diagnosis, as this can not only reduce the risk of getting or delaying dementia, but also slow the progression of the disabilities caused by dementia, and therefore reduce the impact of dementia on society as a whole. I certainly hope this gives you a lot of food for thought and will help make change in the future. Thank you.
Thank you so much, Diana. Powerful words, this. What Diana just told us, that by doing some important activities, once diagnosed, she has managed to slow down cognitive deterioration. This is such an important thing to say to everyone. So there is a lot that we can do even after a diagnosis has actually taken place, because this is a life course issue and we can do something at any stage throughout it. So Diana, I'm sure there's going to be plenty of questions for you at the end of the webinar. I'm going now to pass the baton, so to speak, to Sonia Desuza, who is a carer for her mother who has dementia and who lives in the beautiful sunny lands of the British Virgin Islands. Sonia, the floor is yours. You may need to unmute yourself. We may have a problem with Sonia. So I am therefore going to ask for her intervention later on. Sonia, unless you are on.
To unmute yourself. Sonia, can you unmute yourself? There we go. Lovely.
Okay, thank you.
Yeah. Yes. Adapting to COVID-19, going into the unknown was quite challenging. Walking a mile in my shoe is crucial. Taking care of my mom, who literally blind and have dementia mentally, a resilient spirit was embraced while listening to the BBC News for updates in our local radio station. Emotionally, we will overcome by the grace of God. Physically, I ride my bike, I skipped. As spiritually, I sang songs like Amazing Grace, which was refreshing for my brain. Isolation from the family and friends was difficult. Staying positive on a level was key, with our leader from ADI, which is Edna Williams, our advocate in the British Virgin Islands, help us to focus. For brain therapy during COVID, creating an awareness, I made vegan exotic meals, post them on Facebook, making earrings. On a global scale, our journey of progression continues with excellence that leads to purpose. We must be equipped with courage and ability to press in the new regular with healthy, nutritious lifestyles and making ourselves aware of our dementia by the way we care for ourselves as well.
Sonia, thank you very much for your intervention. I think whilst you're speaking of the importance of wonderful nutrition, I can see the smiley face of Edna Williams in the British Virgin Islands telling us all how much work she's doing in that area. And I can imagine what the wonderful feast that you should tuck into over there and how envious I am about them. But it's also very sad to hear the complexity of having to deal with what you've had to deal through COVID-19 and the reduce and lack of resources that has been a consequence of that. I'm sure there's going to be questions for you that we are going to pick up at the end of the webinar. But right now, I'm going to move us forward a little bit more towards Craig Ritchie. Now, how could I forget? Now this is the moment for us all to wake up, because DY Suharya, our Regional Director for Asia Pacific, will bring us through one of our famous brain gyms. DY, the floor is yours.
Thank you, Paula. Hello, everyone from all over the world. Such a privilege and honor for me to lead this brain gym exercise. I learned this from my dear sister, who happens to be one of the risk reduction specialists in Alzheimer's Indonesia. And we know that based on literature, physical activity can increase the levels of brain-derived neurotropic factor. We hope everybody will enjoy this exercise and hopefully it could help to improve executive decision, attention, memory, and concentration, and will uplift our mood. Sound, please. Just waiting for the music.
Getting us in the mood.
Thank you.
Namaste, DY. Thank you for waking me up. I'm certainly much more awakened now. And just to remind everybody, what we do is not just theoretical, it's very practical. We do need to maintain our gym trained, our brain trained. There you go, I'm already confused. So DY, thank you. This is something you've developed over a number of years. It's been very successful in your practice. And we are collecting now a few of these for our conference in December to use as practical examples of activities that can be done to improve cognitive stimulation. Now,
yeah, and we include the washing hands as well, Paola.
Yes, of course, very good. Yeah, we all get much better at doing that too in the process. So thank you, DY. Thanks a million.
Thank you.
Now, let me move on to the second part of our webinar and introduce you to Professor Craig Ritchie, who is the Chair of Psychiatry of Aging and the Director of the Centre for Dementia Prevention at the University of Edinburgh, as well as a regular contribution to ADI. You will recall that Craig helped us co-chair the panels on the whole webinars on clinical trials last year that were so successful. So Craig, it's a pleasure to see you with us. And before I give the floor to you, I'm going to launch our first poll. So now that we've woken you up, we're going to ask you whether you think there is much that we can do to reduce our individual risk of developing dementia. You have 4 questions, so please, can you vote now? Is there nothing we can do? There is a limited amount that we can do. There is a lot we can do, or you don't know. How do you feel about this question? We have quite a lot of people online, so I hope that we will be able to get quite a lot about that. We are going to leave a minute for your questions. And I waiting to see whether, yes, that's it, we've run the poll. So nobody thinks, yay, there is nothing we can do. Some people think there is a limited amount that we can do. We hope to persuade you that there is more than we can do. There is a lot that we can do, 81% of you, and some of you, still 1% doesn't know. So please stay with us so that you may be able to learn more about those. Thank you very much for this poll. And now, without further ado, I will give the floor to Craig Ritchie to comment as well on the results of this poll, please.
Yeah, so thanks so much, Paola, and thanks everyone at ADI for pulling this webinar together, and for all the great work you obviously do with people living with dementia, but also more recently in recent years around the brain health and the dementia prevention agenda. 81% is a great number. I think we're probably a slightly biased audience, and we're very optimistic. And I think to get 81% of the world's population to believe there's a lot we can do would be one of the challenges, I guess, over the next few years. I think when talking about sort of, global research and global initiatives around dementia prevention, I really kind of think one thing in particular, and that is that Alzheimer's disease and the other neurodegenerative diseases are the same wherever you live in the world. These are the same sort of medical, biological conditions, if you like. But what differs across the globe is the prevalence of the risk factors, which Gill has outlined to us, the access to healthcare, both for treatment and for assessment. And also, I think, local government and national government's appetite and enthusiasm for public health intervention. So although the disease may be the same, those 3 critical factors will affect the course of disease for individuals, no matter where they live in the world. And I think one of the other things I do think about, and some of the comments that were made earlier were particularly relevant, was that what this Lancet Commission report did was outlined, if you like, the key epidemiological risk factors for dementia in later life. But for me, it sits in between sort of 2 other elements. The first, and to the left, is, if you like, what are the mechanisms that explain these epidemiological associations that we're seeing? So what is it that leads exercise to reduce your risk of dementia? And I think Jill alluded to this. What is it about diet and nutrition and food that may reduce your risk? What is it about hearing loss? And when we understand those mechanisms, and we're doing projects like Prevent Dementia Project, like the EPAD project, it certainly gives those epidemiological findings that little bit more credibility. And also, dare I say, when we start speaking to individuals, it gives it salience, because we can then explain why that risk factor or that resilience factor may in fact help their brain health. And the third, to the other side of the Lancet Commission report, is I think this is where the research, I think, has to sort of, in a sense, give way to implementation. So how do you take those Lancet Commission report findings, those risk factors, both at an individual and also at a public health level, and actually put them into practice? And that's one thing that we've been doing now in Scotland, working with government for the last 2 or 3 years, and actually putting in place something called Brain Health Scotland, which is working at both a public health and an individual level to see how you can reduce the incidence of dementia. And I think for me, one of the key things about Brain Health Scotland and initiatives that are similarly starting to develop across the world are, number one, is they work across the life course. I mean, Gill mentioned, for instance, about education, and Paola, you reinforced this about, why is it that people aren't getting a good education? But is it a strong message to say to the educational authorities, you should get a good education because you can reduce the risk of dementia? Or should you be saying to these educational authorities, you should have a good education for a host of other reasons to improve brain health and hopefully, in the longer term, the very longer term, reduce the incidence of dementia? And one of the things we've done, again, locally, is we've tried to move away a little bit from dementia prevention towards using language around brain health. And the reason being, quite simply, that it's a much more accessible, a much more optimistic frame to say, improve your brain health, than do something to reduce your risk of dementia, particularly, dare I say, for people in midlife and earlier. So I think one of the other things, just to sort of conclude, is that what we've done in Scotland is if you like, an innovative service, an innovative policy setup. But what we don't want to do is be parochial with it. What we're trying to do, and we've obviously had huge discussions with ADI around how we can amplify what we're doing in Scotland to help benefit other communities around the world. So just to summarize, I think the epidemiological evidence has really helped illuminate or guide us to where we should be looking for mechanistic understanding of why these risk factors have an impact on the diseases that lead to dementia in later life. And like I said, I think there's a lot of opportunity to really learn about how we apply this evidence in different communities, both within countries and between countries. And it's not that one country or one city or one academic institution has all the answers. And I think through webinars like this, what ADI is doing is facilitating a community of conversations where we can all learn from each other. So I'm very grateful to be asked to be part of this, and very grateful for all the work that ADI have been doing over the years. And I'll stop there. Thanks, Paola.
Thank you very much, Craig. You have raised some really important points there, and I've seen already that there are a few questions in the Q&A that will relate to that. I particularly like the way that you're trying to frame this. This is a bigger issue, and actually works on several levels, and the intervention that you make at any point can actually generate a whole host of issues. To an extent, in an ideal situation, we would like to make all interventions for everyone everywhere. But the reality is that we have to focus where a particular intervention in a particular country at the practical level is going to yield the maximum results. And that's the practical thing that really you're telling us here, which I think we can elaborate further during the course of our discussion. Now, moving on quickly from there, because this is also very relevant, I'm going to introduce you to Nina Renshaw, who is the Policy and Advocacy Director at NCD Alliance. And why did we ask Nina to be at with this webinar? Nina worked for NCDA, and ADI has been a member of NCDA now from the beginning. NCDA is an alliance of organizations operating in a number of non-communicable diseases. That's what NCD means. So diseases that are not contagious. So we're talking cancer, diabetes, obesity, and so on. Because, as somebody said earlier, a lot of the risk factors for dementia are actually shared by these other diseases. And so there is a lot to be gained by advocating together to governments around the world about the fact that if you deal with some of these factors, you've actually helped a lot of non-communicable diseases together. So it's my pleasure to give the floor to Nina. But before we do that, we are going to have another poll just to keep you on your toes in case you think you can relax. The question this time is, to what extent do you think that there is a need for policy actions to tackle the risk factors? You have here now 5 questions. And the top line is one where there is already enough policy action, so we should not do anything. And at the other end, there is an urgent need for more policy action. So the other questions, answer 2, 3, and 4, are gradation of that. So mark them according to their importance in your mind. There is already too much, or we really need to do more policy now, please. And as before, we got a bit less than a minute to do this. And then hopefully we'll get enough answer and move on. There we go. And here are the results. Nobody thinks that there is already enough. 3% to 9%, 27% 4, but the vast majority of you, 62%, think that we need to make policy work immediately now. We need more policy. So Nina, over to you. Thank you.
Thank you, Paola, and thanks to everybody that just completed that survey. I obviously was very much hoping that you would say that there's an urgent need for more policy action. So I'm preaching to the converted. So this is great news, not an uphill struggle for me to talk to you today. Thank you very much for the invitation, and thanks especially to Gill and all of the co-authors and supporters of the Lancet Commission report. I think for policymakers and decision makers, politicians, the findings have to be very empowering. And we need to transmit that to our politicians, that these findings are empowering, but also put some of the responsibility over to them for dementia prevention. The findings of the study are very complementary to what we currently have in terms of international policy approaches for all non-communicable diseases. So we have what's informally called the 5x5 approach in NCDs, and this is at the United Nations and at the World Health Organization levels. So it looks at 5 major groups of NCDs: cardiovascular, lung disease, cancers, diabetes, and mental and neurological conditions, where obviously dementia is included. And then 5 major risk factors, of which 2 that have been picked out as new risk factors for dementia in the Lancet study. So use of alcohol and air pollution, which is really welcome from our perspective to see, and extremely important, especially air pollution. I mean, this makes very clear that this isn't, you know, a personal intervention. You can't do much about where you live, where you work in terms of your exposure to air pollution. So this really is absolutely, but across the whole suite of risk factors, a responsibility of politicians to take action as well. Precisely as Gill was saying before, unhealthy diet is very much a product of your food environment, what you can afford, what's accessible, how that compares to other things that are available in your local settings, to your families, and so on, as a function of your budget. Likewise, tobacco use, there's an awful lot that can be done from the policy level about tobacco control, plain packaging policies, no smoking policies in public spaces, and so on. Likewise, alcohol, physical activity, air pollution, there's an awful lot that can be done to catch up there. So this approach has really been extremely, extremely useful. What's not adequately represented in this 5x5 is the interlinkages, which the report pulls out very, very well. The interlinkages between NCD conditions and the clustering of risk factors, and particularly in parts of the population who are marginalized and stigmatized in various ways. So, you know, we're also seeing that people living with multiple NCDs, people living with hypertension, maybe type 2 diabetes, you know, are susceptible then to other conditions. And this is becoming kind of the norm much more than the exception. But policy so far doesn't do a very good job of recognizing this and acting across the whole suite of risk factors and NCDs. The linkages that you've highlighted, particularly in relation to obesity, hypertension, diabetes, and illustrated the contributions of the cross-cutting risk factors, poor diet, alcohol, tobacco use, and so on. This is extremely important and something that we do have to get across to policymakers. If I can have the next slide, please. I wanted to just briefly highlight the latest IHME, also another Lancet study on the global burden of disease, which has shown that, you know, the global burden of disease, NCDs are the biggest driver of premature death and disability across the global population. That's the other thing that the Gill study does particularly well, is highlight that this is not just the case in higher income countries, but also in the lowest income countries, low and middle income countries very much as well. So there's an importance to point out and articulate the research gaps and what needs to be done in lower income settings. I think there's a increasing appreciation, and that's sort of highlighted by this quote from the director of the Institute for Health Metrics and Evaluation, who put together the global burden of disease figures, that in global health institutions, policies, and especially in financing, NCDs haven't caught up with the reality of how many people are affected. We know nearly a quarter of the global population are impacted and living with at least one NCD. And these are people who right now, of course, feel very much at risk from COVID. If I could skip through to the next question, please. The next slide, sorry. So, I mean, to the question whether COVID-19 risks derailing action on prevention, I suppose the short answer is, you know, in the short term, yes, that seems to be happening at the moment because of the major disruptions that we're seeing in NCD care and NCD prevention programs, and increased exposure to risk factors at the moment. But, you know, the better answer is it absolutely doesn't have to be the case. The syndemic that we're seeing between NCDs, but also inequalities and COVID, that has to highlight that there's plenty that we can still do, and that should be an empowering message as well. But it really gives us a policy window, and it shines a spotlight on these interactions, also between communicable and non-communicable diseases, which possibly had been very much underappreciated in policy before. So if I could have the next one. So what I want to present is that there's actually a huge opportunity now. That window of political opportunity and awareness of decision makers is very much shifting. We're shining a spotlight on the long-term neglect of NCDs, conditions including dementia, and the risk factors that have exacerbated the pandemic. So by presenting this very empowering message that there's much, much more that we can be doing for prevention across the whole suite of NCDs, and acting on all of the risk factors, this is also quite an empowering message as well in terms of our global future health security, and being better prepared for future epidemics and future health threats across the board. I think there's also a new focus on accountability, and it's absolutely fair that the civil society, people living with NCDs, academia ask the question, why are some countries doing better than others right now? What's the difference? And why are some population groups doing better than others? That's also coming through in Gill's report. And that gives a new urgency. If we frame this as part of health preparedness and security, as well as equity, hopefully that gives a new catalyst for policy action. So yes, there are, I think, on the optimistic side, if you go through to the next slide, please, there are signs that this syndemic of COVID and NCDs can be a catalyst for change. The media and the political attention to NCDs right now, and the recognition of the urgent need to provide universal health coverage for everybody is absolutely unprecedented. So this is a moment for all of us who are advocates for dementia, advocates for NCDs, to kind of pick up that gauntlet. What I want to leave you with is, you know, the Commission findings are incredibly valuable, coming at a time when it really coincides with this window of opportunity for overdue policy action. Within NCDs, and now that this is really shored up by the messages for dementia as well, we have a really good evidence base for what works. There are the NCD, what's called the best buys, the tried and tested policies from WHO. And now with the findings of the Lancet Commission, it kind of shores it up in 4 different ways. The recognition of the clustering of risk factors and of the bidirectional relationships between different NCDs, and the number of people living with multiple chronic conditions at the same time. Secondly, it makes a much stronger investment case. We can say that if you take action to control hypertension, to control diabetes and so on, this is also going to have preventative advantages for dementia. And we can factor that in as well to the investment cases for taking these preventive and treatment NCD actions. It should also inspire governments to take some policy choices that they've been basically too cowardly to take before, When we look at some of the industries that produce health harmful commodities, the governments have shied away from taking action, like junk food, alcohol, air pollution, those two new ones that have been picked up in the report. Now is the moment to really, for all of us, to push harder for government action on these things. But also social determinants, poverty, deprivation, lack of access to education for all, lack of access to healthcare for all, inequality within and between countries. All of this shores up, makes that case, makes that investment case so much stronger for the best buys, which will help us not only reduce prevalence of NCDs, but closing the health gap between different parts of our communities within and between countries. And also we can add to that list now better preparedness, better health security for future health threats. So yes, I wanted to, again, to thank the team behind the Lancet Commission report very, very much for what you've added to the evidence base, and say that from perspective of advocates, we understand that the gauntlet now passes to us to make that case even stronger. So thanks very much, everybody.
Thank you, Nina. Thank you for a very good and very clear presentation. Can I also remind everybody, with reference to your second slide, that the numbers of people that are now coming out having died of COVID with dementia have been quite stark. So we are talking of about 20% in certain regions of Italy, up to 26% in the UK, up to 66% in Canada, which are shocking figures. And in all of these, we still have an issue in general at international level in getting figures from governments, because even if the WHO has asked, for example, various governments for data around NCDs, data on dementia is not being collected and gathered. Very difficult to get the data. They will collect data on cancer, on obesity, on these other individually named diseases, but dementia has been really tough. And this is why we need to bring constantly to the attention of the wider NCD movement the fact that dementia is actually one of the biggest killers now worldwide, and certainly has been around COVID. So we all continue to work with the NCD Alliance in order to sort of make sure that this point doesn't get lost, as currently it is being lost, and as denounced very effectively by Gill herself, actually in some of the recent papers. So Nina, there is a lot of very good feedback for you and a lot of questions, but I'll move on briefly to Dr. Melinda Power, because I know that both you and Dr. Power have to leave us on the dot. Dr. Melinda Power is Associate Professor of Epidemiology and Director of the George Washington Institute for Brain Health and Dementia. Now, Dr. Melinda Powers is on this webinar in particular to talk to us about the very interesting points that have come out around pollution and dementia and what can we do around that, and to drill a little bit deeper. This is something we haven't talked about yet because we were reserving it for Dr. Powers, who has also asked us the following poll question: were you surprised, you audience, to see air pollution listed as a risk factor for dementia? Please answer that now. Yes, no, are you not sure? So as usual, we'll leave you a few seconds for answering that question, and then we'll see where you are with that. Okay, so the results are yes, you were surprised. 40% of people had no idea. No, 54% of people had some idea. Not sure, 5%. So actually, everybody's kind of divided on this one. Well, Melinda, you no doubt will be able to comment on that. So the floor is yours.
Thank you so much for the kind introduction. So today I'm going to talk a little bit about air pollution as a risk factor for dementia. And actually, usually when I talk about this, the audience is much more surprised. Next slide. So just to get us all on the same page, you know, what is air pollution? When we talk about this, we talk about a lot of different things, right? Air pollution is not just one substance. It's a lot of things that are present in our air. It includes particulate matter, nitrogen oxides, sulfur dioxide, carbon monoxide, ground level ozone, VOCs, and lead for the most part in terms of health effects. Notice I'm not talking about a lot of the air pollutants that are associated with climate change. These are not necessarily as linked to health effects, although there is some overlap in terms of ozone and particulate matter. So where does it come from? It comes from power plants and industrial processes. It comes from cars and trucks. It comes from construction and agriculture, and there are also natural sources of air pollution. Next slide. So when we think about how air pollution could cause dementia, there's a number of really interesting mechanistic hypotheses. If we start on the left, there are potentially direct effects. There are ways that the air pollutants, you can breathe them in and they can either go straight from your nose to the brain or into your lungs and then through your blood to the brain as well. And they're associated with inflammation, oxidative stress, protein aggregations, and cell death. If we think about indirect effects, there's a lot of ways that air pollution can contribute to brain health as well. So we know that what's good for your heart is good for your brain, and air pollution, on the opposite, not good for your heart, right? We know that air pollution has bad effects for your cardiovascular system. So that's another pathway by which air pollution could impact brain health. And then finally, air pollution is just associated with systemic inflammation. And a lot of our neurodegenerative diseases are at their base inflammatory diseases, right? There's a lot of inflammation associated with those processes. And so there's another mechanism. We don't really know exactly which of these are true or if any of them are, but these are the mechanistic hypotheses that prompted this line of research. Next slide. So what evidence do we have that air pollution causes dementia? Well, at the basic level, we know that people who live in areas with more air pollution appear to have worse cognitive health in late life. So this doesn't mean that all air pollutants are equally related to dementia. Most of the studies that are out there right now look at particulate matter. So that's essentially soot or dust in the air, little particles of things that are suspended in the air. There are other studies that have looked at oxides of nitrogen and traffic-related air pollution, but most of the research thus far is on particulate matter. And it's nice because when we do research on dementia, we look at it with a whole bunch of different lenses, right? We look at air pollution and cognitive performance. How well did people do on cognitive tests? We look at incident dementia, but we also get to look at biomarkers or neuroimaging markers of the disease. So for example, here we could look at a brain MRI and see how air pollution would be related to different changes on MRI. Now, this literature is still kind of forming. I was really excited to see it as part of the Lancet Commission's report, but I think there's a lot more work to be done here, although it does look extremely promising. Next slide. So what's next, right? We know that air pollution has other health effects. It has established effects on heart health and respiratory health. As we talked about with the last speaker, air pollution is one of those things that's best leveraged through policy, right? Air pollution can be reduced through either governmental regulation or industry commitment. We're seeing that in the United States, that a government's doing less right now on environmental regulations, but industries are often doing more because of global influence or state level influence. This can have a large impact on health. In the United States, the Clean Air Act is by far the most cost-effective piece of legislation that was ever passed. And it's more effective than individual level efforts. I know many of you, if you've ever tried to be on a diet, if you've ever tried to convince yourself to go get more exercise, it's really hard to change individual behavior. It's these types of passive, high level interventions can be really effective. And there's also I think this area of research is going to grow as time goes on. There are a number of other pollutants, things like pesticides, things that we find in our water that may also be related to brain health. They're plausible, but there's just really very little scientific work on this area thus far. And I'm hoping it's an area that people will be more interested in looking at in the future. So thank you very much.
Dr. Power, thank you so much. Such an interesting presentation on such a complex issue. Now, we are going to go into Q&A because we haven't got a lot of time. And I thank all of you who are still online. I see there's a lot of you. First of all, I know that Dr. Power and Nina have to leave. So I'm going to start with you with Dr. Power. We got an interesting question that came before the webinar. And the question was, in the Lancet article, Dementia Prevention, Intervention and Care, carbon monoxide was mentioned once, but there is no mention of indoor air. Pollutants are more concentrated indoors. Brits spend over 90% of their time indoors, as do so many living in colder climates. And interestingly, in the question, we just had someone saying that they've installed HEPA filters all around the house. So this is an interesting example of where we go from the complexity of research to the practicalities. Does it make sense to have HEPA filters all over the house? So please, could you give us some sense of what you think around that?
Yeah, so if we're talking about indoor air pollution, the biggest determinant of indoor air pollution is usually outdoor air pollution, right? And so if we think about what's in the air more generally, that's what's going to be in the air in your home. There are sources of indoor air pollution. They're less studied in relation to kind of health effects, but we would imagine that the mechanisms would be the same. I don't think it's a bad idea to have air filtration, but I also think on an individual level of risk, there's so many things that I would do before I would go there, right? I would think about my blood pressure. I would think about all those other risk factors that Gill's report highlighted as things that are potentially, just as or if even not more important than kind of something like air pollution indoors.
Thank you so much, Dr. Powers. Now I will move, and so yes, HEPA filters are probably a good idea, but then it depends on where we live, which is a very effective point. We'll move quickly to ask a question to Nina before you have to jump out of the call. Nina, somebody on the Q&A was pointing out that your presentation was excellent, and they didn't know the NCD Alliance also worked on dementia. So can you tell us a little bit, how do you feel that the dementia discourse is fitting within the NCD discourse? You work a lot with us. Is there more that we should be doing about communicating to people how dementia is a non-communicable disease? What can we do to explain more the linkages and make more of our partnership?
Thank you. Good question. I mean, obviously, we've been working together now for a really long time. I think ADI has been on board since almost the very beginning of NCD Alliance as a member, and it was great, Paola, having you on the board for a few years as well. It's been extremely insightful. I think what the Lancet Commission shows is just how many interlinkages there are between different NCDs. This is something that I have to say, including with regard to dementia, we're learning about this all the time as well. There are still quite some important research gaps when it comes to multimorbidity, by which I mean people who live with more than one chronic health condition at the same time. So there's a study from a couple of years ago from, I think it was the Australian Society of Medical Research, which estimated that, and the bandwidth is huge, that between 13 and even as many as 95% of people who live with an NCD are actually living with more than one. So that bandwidth is so huge really shows you how little we know. And that was based on, I think, UK and Australia data, so high income country data. Obviously, the data gap is even bigger for lower income contexts. But there are estimates which, say that there could well be billions of people worldwide, at least 2 billion people worldwide living with, several NCDs at the same time. There's something to be said as well for, living with NCDs and then affiliation with chronic diseases. So people living with HIV, for example, are a higher risk of hypertension, diabetes, and other NCDs. People living with TB, for example, have a higher risk of having other chronic lung diseases at the same time, also diabetes again. So I think we're just finding out about all these interconnections and interlinkages. And that coupled with the major risk factors is what really pulls us together as a community. It's very hard, as we know, as you know, to convince governments to take action on social determinants and on commercial determinants, because this is, inconvenient for them, especially if they're countries who have major producers in the fields of junk food, of alcohol, of tobacco, and so on. So I think, there's a huge need for us and people living with NCDs to come together as a community, like a 2 billion people strong community of NCDs, to try and get these messages across more strongly to governments. And as I was saying, I think, this syndemic with COVID, makes our hand even stronger, frankly, to talk to governments on that basis, because maybe what we haven't had enough of before is a kind of urgency for policy action. NCDs are very much seen as a slow burner as compared to like the acute crisis of COVID or the acute crisis of HIV back a couple of decades ago. And maybe this gives us the moment to say, no, this is an emergency, a global emergency. The NCD pandemic also requires an emergency response, which means that governments have to face off with some of the industries and some of the tricky policies that they haven't had the courage to do before. I hope that answers the question, but I think just in short, there's much more that we can do together. We've always enjoyed working with ADI, and I think the opportunities going forward are bigger and better on the basis of the new evidence. So really, really grateful for that. Thanks. Oh, did we lose Paola?
I think we might have lost Paola indeed. I'm hoping she'll dial back in soon. There are quite a few questions. Maybe Chris, could you jump in?
All right, I'm just switching my camera back on. Hopefully you can see me as well. Laura, can you hear me okay?
Yes, I can. Yeah. Thanks, Chris.
Nina, thank you so much for that. Nina, just as a quick follow-on to that very specific question, in terms of some of the other NCDs, obviously some of them have really come to light over the COVID period as well. Which other disease groups do you think the dementia community could work well with? And I'm thinking specifically, around this risk reduction angle as well.
Guys, by the way, I've managed to get myself back on. Thank you, Chris, for taking over. Yes, sorry, my Wi-Fi went down. Nina, can you be super quick? Because I've got about 3 questions for Gill and the others. We've got only 5 minutes. Thanks.
Sure. Yes, I can be very brief with that. I think what's come out of the Lancet study, especially around alcohol and air pollution, these are really important new frontiers where, policy action has been woefully lacking at the global level. There's a need for the WHO to catch up and deliver some best by policy recommendations around air pollution in the near future. There's also WHO are developing a global action plan on alcohol action. So the contributions of the dementia community there would be super welcome. That's over the course of the next year. And also next year is a huge opportunity to take action in relation to healthy diet policies. So there's going to be a UN level food systems summit in September, where it would be great to see the dementia community represented as well. And there's also a Nutrition for Growth Summit at the end of next year in Tokyo, which will bring the global health community together. And, the dial is gradually shifting away from undernutrition and that end of the malnutrition scale more towards obesity and overweight, where I think also the dementia community has a lot to offer in terms of evidence. And your voices may be unexpected in this context, and I think that makes them all the more welcome.
Thank you very much, Nina. Now I'm going to jump back into the rest of the panelists, and most importantly, Gill. Gill, we've had some practical questions around 3 particular issues. One of them is around sleep problems. Sleep patterns don't seem to have made it to the top list of risk reduction factors. Can you tell us a little bit more about how the Commission worked on that?
Yeah, I can. When we re-met, we had a sort of list in which we tried to search the literature and look at the evidence, and one of them was sleep. And the literature shows that sleeping less and sleeping more are both risk factors for dementia. And the Commission felt that that was biologically implausible, that it could both be, and felt that it really wasn't very clear how much of this was reverse causation. So as people are developing dementia, they sleep worse, and how much of it was due to other factors which were also a risk factor for dementia. So for example, people who are who have cardiac problems might sleep more or have more disturbed sleep, or people who are depressed might either sleep more or less. So while we felt that sleep probably is important, we felt it really didn't it hadn't quite made the cut of us understanding it. And we really need to consider studies which take place 10 to 15 years before, and to account for all comorbidities, including medication. There wasn't enough evidence yet. So we did talk about sleep, but it didn't quite make the cut of something which there is extremely convincing evidence.
Thank you very much, Jill. There is also another couple of points which are raised later. I wanted to try and bring in also Craig a second. Craig, there was an interesting question for you around how could we apply the kind of international research that you have done, and especially the best practice, to local context. The question was coming in particular from someone in the Caribbean. So how can this kind of research developed in higher income country can be applied in the lower income country context?
Yeah, well, I think there's two parts to the answer. I mean, one is, as you know, we're developing relationships through ADI with colleagues in Jamaica and Indonesia and other parts of the world through a learning forum we're pulling together. So I think, and in that, what we do is we share ideas. It's not, I don't think it's a matter of us, you know, doing research here and then distributing it to the rest of the world. I think it's about having conversations, because there's a lot of research is done on the ground in these communities, which can inform how we do things here. Because like I was, the second part is that, you know, within countries, I mean, Scotland's being is a very good example. There is massive socioeconomic disparity. So what might work in, you know, the West End of Edinburgh is totally inaccessible to other parts of the community. So all the research we do always has to have a weather eye to how that can actually be applied globally, not just between countries, but within countries where there are, you know, almost always quite stark socioeconomic, you know, disparities. So I think, number one, let's have dialogues like we're having now, take things offline, have focus groups, have workshops, you know, share ideas with each other. And the second is, when we do research, make sure that in the DNA of all of that research is its potential for globalization.
Thank you ever so much, Craig. That's a good point. And can I remind everybody that kind of conferences that ADI runs as this webinar are exactly to enable that kind of exchange. And let's be clear, there is also excellent research that is being done in lower income countries, and that needs to find a bigger platform as well. So the exchange goes both ways, and we are all learning a lot all the time from each other. Now, I'm gonna bring it back a second to Diana and to Sonia. There was an interesting question earlier about the fact that despite everything that people say around hearing aids being useful, in many, many countries, these are still only affordable to people in higher income brackets or not affordable at all. So Diana, could you tell us a little bit more about the experience of fellow members of DAI? Is it easy to get hearing aids? And then after Diana, Sonia, can you come in and tell us your experience in the BVI, please? Diana first. Yeah.
Sure. Well, unfortunately, from what I know here in the United States, most hearing aids are not even a covered item for insurance. And so that the accessibility, even in the US, is minimal. Really, it's limited to those with the financial means. And I expect that's, from what I'm hearing, I'm expecting that's very similar in a number of other countries, that even if you have what they like to call socialized healthcare, that there's still limitations as to who gets what healthcare and how long it takes to get that healthcare.
Thank you very much. And can we please hear from Sonia?
Yes.
Yes, on this issue of are hearing aids available in the BVI? Do you know if it's easy to get hearing aids?
I'm not hearing you clearly.
Yeah, sorry. The question is about hearing aids, the fact that they are not available often to people in lower income brackets, or they're not available in lower income countries. Do you know how easy it is for people in the British Virgin Islands to get hold of hearing aids? I'm sorry, it's my pronunciation. Italians cannot pronounce H, famously, at the beginning of
Yes, in the British Virgin Islands, through the health care system, the Ministry of Health, they aid in helping on people with the hearing aids.
So there is no help, have I understood correctly? Like in the States? Sorry, I think I'm not hearing well, but I think I understand that in both cases, in the case of Diana and the case of Sonia, hearing aids are not widely available. So one of the practical policy action calls, you know, ADI is all about practical things, is to try and make sure that something that is so useful, we should be trying and get governments to put on the list of the important things that people should get, in order then not to be socially isolated and all the useful things that Gill was telling us. So this is something we'll keep in mind for our next advocacy. I'd like to finish with one question to Gill. And this comes from our incoming chair, Dale Goldock in Canada, who was in practice asking, given that we know that singing is good for people living with dementia, is one of those activities that prompts a number of reminiscences as well, has there been any study around whether singing in general, music, therapy and singing are useful as a preventative thing not to get dementia? Gill, that's...
Sorry, I was just unmuting. I think that in general, the evidence is that doing things is good for your brain. So I think when people quite often advocate the thing that they particularly like doing is particularly good for brains. We haven't really been able to see evidence of that. I think that doing things like singing makes you cognitively engaged, socially engaged, and is enjoyable, and probably reduces the chance of you becoming depressed. And I think that that's true of most things that you people enjoy doing, that they are good for your brain, and not that. I think you can get into a little bit of a sort of rabbit hole if you look at every single individual possible thing. I mean, so I advocate keep doing what you enjoy and do lots of it and lots of different things, and your brain is much more likely to be healthy and you're less likely to get dementia. And I'm at the stage of my life I've stopped worrying just about brain health. I'm worrying about dementia.
Thank you so much, Gill. There are stages in which we have to worry about brain health, and I think I love the way that Craig put it. Is a positive way to look at the fact that we should be looking after our brain health generally. And there are stages of life in which that's definitely important. As Gill says, there are other stages in which we're just worried about dementia. But nevertheless, the important thing of this kind of gathering is that we make sure that anything that we can do at this stage to help, we discuss so that we can then action. Now, our big job is how do we make all the rest of the world aware of that? So that is where the work of ADI will continue, increasing awareness, talking to governments, trying to move this discourse forward. Now, I'm very proud that we're only 7 minutes over. So I'm going to leave you with our last few slides. One is to remind you that this webinar, is everything we do, is free. Therefore, if there is a possibility you could make a donation, please do. And the second thing I'd like to remind you, the next slide, is that we are going to run a very large conference very, very soon. Many people are going to speak at this conference. That's going to be the 10th to 12th of December. You can register until very late, and please do get in touch if you would like to know more. Thank you very much, as ever, to my team. In particular, thanks to Chris Lynch, which covered for me during my terrible Wi-Fi provider, cutting my link and showing you once again how many people are behind the scenes of this webinar. I also like to thank in particular Annie Bliss, Laura DeBas and Wendy Widener, who are part of our webinar team, and we talk all the time, but so also with the rest of the team of ADI, who is very much behind the scene, following and making sure that everything goes smoothly. So thank you very, very much, everybody, for staying with us. And again, the slides and the webinar will be available online very, very soon. Thank you and goodbye.